So yes, I do have a couple of questions following up on the item where we asked about the comprehensive assessments. After the comprehensive assessments are conducted, how is that information applied or used so that it doesn't, so it's useful before it becomes stale?
Can you repeat the last part of that?
On the comprehensive assessments, how do you apply that information or use it? If it's assessment occurs and then the information is not used, obviously that information is stale and one would have to do another assessment. So I was just wondering how that's done.
There's a couple of ways. One is, which in statute, there's a requirement for each of the comprehensive assessments to be updated on an annual basis during the IPP process. But the regional centers also include what is identified through the IPP process and comprehensive assessments as far as what the needed resources in the community are to support individuals' needs. And at that point, regional centers include what the development or unmet need for resources in their community placement plans to be able to ensure that the community resources will be available. The ability to develop those resources certainly takes a little bit of time. It's not something that's going to immediately happen. Sometimes it may take a couple of years to develop those resources, but it is something that is a guiding tool to help develop and focus their efforts at development.
And then the last question would be, what happens to unspent CPP funds at the end of a fiscal year?
CPP funds historically in some situations, or certainly some of the unspent funds, have been redirected to other needs over the last several fiscal years, and then those funds that have not been redirected within the department, they are returned to general fund.
So they're completely fungible? What sort of needs are they spent on?
When there's, in the last several years, when there's been a shortfall because of some of the unallocated, as an example, there was a $100 million trigger. Some of the unspent funds during that fiscal year, there was also some of the CPP funds that were a part of that plan to meet that requirement.
Do you have any numbers on how much of the CCP fund has been sent back to the general fund?
I don't have that available, but we can certainly go back and get back to you on that.
Okay, that'd be great. Thank you very much.
You're welcome.
All right. Sorry, Department of Finance, I haven't been asking you lately if you had any comments. Do you have any comments on any of the issues above? All right, thank you very much. Legislative Analyst's Office. Thank you very much. I knew you would probably pipe in if need be, right? Thank you very much. Please do that if I miss you. All right. Okay. Let's see. Where are we next? We are on issue number 2. Let me just turn my pages here. Issue number 2, purchase of services. And if you could please give us a quick little overview, and then you can go straight to the minimum wage increase.
Okay. And actually, I'll just go straight into minimum wage.
That's fine.
Okay. So AB 10 raises the minimum wage, as we had just stated, that from $8 to $9 effective July 1st, 2014. The governor's budget assumes that many providers will be impacted and will require rate increases in order to pay employees the new minimum wage. The process for adjusting rates for minimum wage increase will happen in 3 ways. The provider-specific rates set by the department. Providers will then submit to the department a wage data that will specify employees that are paid less than $9. For providers that have specific rates that are set or established by the regional centers, that information will flow through the regional centers as far as the service providers and the staff that are paid less than $9. Examples of these two: for service providers, that specific rates are set by the department. These are community-based day programs, in-home respite, work activity programs. For provider-specific rates set by regional centers, these examples are supported living, transportation companies, and so those are some examples that would be impacted by the rates set by the regional centers. The residential facilities under the alternative residential model, also known as ARM rates structure, and individual respite providers, DDS will adjust these rates. The providers on this category do not need to submit any information either to the regional center or to the department. The amount included in the budget for minimum wage increase was developed using assumptions on the number of service hours provided by employees making less than $9 an hour. As an example, under the alternative residential model, the ARM rate structure, we know that a level 3 provider requires 190 direct service hours, and based on our analysis, it is our assumption that 100% of those staff are paid below $9 an hour. From there, we were able to build an assumption to project the impact of that cost. Cost included, and the projection includes related to mandated employer costs such as Social Security, unemployment, or workers' comp. The proposed TBL addresses increases for all services with rates established by the department or by the regional center. For supported employment providers, the services where rates are set by statute, DDS is unable to determine the composition of the current hourly rate. Therefore, we are unable to determine if the minimum wage increase is warranted. DDS is aware of the concerns expressed by service providers. A number of the concerns that they have is certainly the timing of when we're going to be able to get communication out, and we are anticipating that we'll get communication out the first part of April to give them guidance on how to move forward with making the request for these changes in the rates. We're also aware of the concern that's been addressed about the employees that are making less than $9 an hour and does not include funding for the maintaining employees on the exempt status. We continue to work with Lanterman Coalition to get input on the process of being able to roll out, and we look forward to meeting with them again before we actually send out the instructional letters. The rates increase granted by regional centers and the department will continue to be reviewed by the department, and will do so by ensuring through the regional center audits that the department does. The proposed TBL requires regional centers to maintain documentation for any rate increase due to the minimum wage adjustment. Any questions on minimum wage before we go to federal labor standards?
Department of Finance, Legislative Analyst's Office.
Thank you. Rashi Kesarwani, LAO. The governor's budget proposes $69 million general fund to provide rate increases to vendors that are expected to incur additional costs as a result of the minimum wage increasing to $9 beginning July 1st, 2014. The governor proposes a flexible approach whereby most impacted vendors would be able to provide documentation to either the department or to the regional center as to the minimum wage exposure that they have. Because of data limitations, we agree with the administration's flexible approach of allowing vendors to come forward to provide that documentation. We therefore recommend that the legislature approve the governor's budget proposal to provide $69 million general fund. In our recent analysis, we further recommended that the legislature maximize its oversight by creating a separate appropriation to provide rate increases as a result of this higher minimum wage. The intent of this recommendation is to track how much is ultimately spent on these rate increases and to ensure that the funds are used exclusively for minimum wage adjustments. However, in subsequent conversations with the Department and Finance, we've become aware that the separate appropriation could be administratively burdensome to vendors. So we are now evaluating alternatives that would achieve our intent of tracking the amount of funds spent and ensuring that they are used for the minimum wage. We're seeking a solution that would provide legislative oversight without being overly burdensome to vendors. Finally, we'd like to note that the supported employment program providers would not receive a rate increase or be able to request a rate increase based on the administration's existing trailer bill language, as Nancy Bargman has noted. We're continuing to evaluate whether supported employment program providers should have a means to be able to request a rate adjustment.
Okay, thank you very much for that. Next item is the federal overtime changes.
Thank you. governor's budget addresses implementing changes effective January 1st, 2015 to the Federal Fair Labor Standards Act that addresses overtime compensation for service providers that previously were not required to pay overtime. The changes in the federal rule affect those who provided services that may fit in the federal definition and companionship services. For the department, this applies to supported living, respite, and personal assistance services. To address the federal changes, the governor's budget assumes a 2.25% rate increase for in-home respite providers, supported living, and personal assistance providers. The proposed increase to assist providers is to help them manage the administrative cost associated with complying with the new federal rule change. Estimating the increase was a complicated process, and because we do not have the level of detail and the data on the hours worked by each individual employee, therefore we used information from IHSS on the number of hours their employees work as a base. It was assumed that regional center funded services, on an average, are provided at 50% greater frequency than IHSS due to the needs of the individuals that we provide services for. Therefore, the potential for employees working more than 40 hours per week is greater than that in IHSS. Applying this assumption to the IHSS information resulted in an estimated 2.25% increase in expenditures needed to enable providers to manage within the new federal rules. There have been questions about the interaction of IHSS and regional center funded services, specifically supported living. There are approximately 56,000 regional center consumers who receive IHSS services. However, all of these individuals are not necessarily receiving IHSS services as well as supported living, respite, or personal support. We do know, however, that based on our current data available to us, that approximately 4,300 individuals of the 56,000 also receive supported living services. We are in agreement with the Department of Social Services and the fact that the state is considered the third-party employer for IHSS and DHCS waiver personal care services, while the regional center vendors are solely liable for overtime for their employees, just as they are today. The state is not the employer or the third-party employer in the DDS system. We acknowledge that the federal rule changes for some regional center vendors may be subject to overtime requirements in ways that they were not previously. While we don't fully understand the total number of consumers whose family members providing the services directly through a regional center vendor, we do know that there's approximately 2,500 consumers and families that self-direct their regional center services. DDS will continue to work with stakeholders on the impact of these changes and understanding in the unique situations that we're just not aware of today. Any questions regarding the federal overtime?
Yes. Could you please repeat the number of regional center clients that receive IHSS services that you stated?
Certainly. There are approximately 56,000 regional center consumers who receive IHSS, but again, this number does not indicate that they're also receiving supported living, respite, or personal support services. We do know, based on the current detail available to us today, that of that 56,000 individuals, that we do have 4,300 who are also receiving supported living services.
Okay, thank you very much. Department of Finance, do you have comments on that? Legislative Analyst Office?
Yes, thank you. The federal overtime rule requires employers to pay home care workers overtime or time and a half for all hours exceeding 40 in a work week. The governor's budget proposes $4 million general fund in 2014-15 to provide a 2.25% rate increase to vendors of supported living, personal assistance, and in-home respite in order for these vendors to mitigate the fiscal impact of the new federal overtime rule. We think it's reasonable to assume that vendors will incur increased administrative costs, such as the costs of hiring additional workers, as a means of ensuring that no worker is exceeding this 40-hour work week cap. not necessarily a cap on the hours worked, but in terms of needing to pay overtime for hours that exceed 40 in a week. Because of data limitations, we're uncertain whether a 2.25% rate increase is the right amount. We therefore recommend that the department report to the legislature on the results of the rate increase on impacted vendors in order to assess whether a 2.25% increase is the right amount on an ongoing basis. The department could potentially gather and report relevant information, such as the average number of new employees that were hired by vendors based on organizational size, the average administrative cost of hiring a new employee, or other methods used by vendors to mitigate the impact of the overtime rule.
Okay, thank you very much. I do have a couple more questions. You have referred to data limitations a few times, and I'm just wondering specifically, what do you mean by that?
On the being able to ascertain the specific information regarding what compiles the 2.25%. The information available to us to get into that level of detail is not something that we presently track, and certainly being able to identify the number of hours that is paid overtime at the service provider level is not something that's available. Several years ago, the department, in fact, did not, as a response to the rate freezes and cost containment, we stopped actually even reviewing the cost reports that were previously submitted by service providers that would let us see some of the detail. We just don't have a mechanism in place at this point to get to that level of detail to give us clarity to what that impact would be.
Okay. I also have another question. Obviously, we've been discussing the concern about overtime and what this may look like and what the practicalities are. Do we have any sense that if we implement a program that does not allow people to work overtime, whether there are additional workers out there to be able to provide these services? That's the big question.
Yeah, we don't have
know?
clarity on that.
Do we have any idea whether there's enough workers available? And also, in the situation where a family member might be a caregiver, do we believe that it might be appropriate to bring in another worker when a family member's available?
Certainly, as I was saying a little bit ago, as far as the situations where the family is the direct care and they have self-directed services, you know, we're concerned about what that impact may be. You know, we do recognize that for the families that are paying directly, that they still have the ability to maintain the exempt status. However, if they are a parent provider as far as being with a vendor, that changes the situation. We continue to hear and want to know what those concerns are, but at this time, it's just, again, I apologize, we just don't have clarity on that issue.
Well, I don't think anybody knows the answer to the question. Yeah. Would you say that may be correct? Yeah. It's a big issue, big concern.
And as we move forward, I think we'll have a greater understanding of the impact.
Yes. Thank you very much. Senator Monning.
Thank you. I think we're about to hear probably some very specific concerns about impacts, but just in the framing of the overtime. So one metric is the potential increased cost, but just so I'm clear, in the governor's budget proposal, there's no distinction made between an in-home support service provider for somebody who may be a family member unable to care for themselves versus somebody with a severe developmental disability who's had an ongoing relationship with a care provider who is sensitive to that person's needs, that to artificially cut them off at 40 hours, there's not necessarily a substitute provider who can fill in with that knowledge of the recipient of services. So Does the governor's budget contemplate how do you deal with those particular situations where that disruption in service, it's not just economic, it affects the continuity of care and potentially the safety and life of that individual?
See if I can approach this in a couple of ways. One is that with in-home support services, if you have an individual who is employed as an in-home support services worker, they are employed as a different employer. So under the regional center, then if that same individual is working as a vendor, under the employment of another vendor, that is also something that will separate then the overtime issue. So there's some continuity of care that can still be established. I guess I kind of liken it to an example. I'll do my best in an example, and probably not very good at telling stories, but let me give it a try. So if you go into a convenience store, at a gas station, and you see a Subway in that store. So Subway may be the employer for the person who is serving, making up the sandwiches, and then then their next job is working within the gas station, but it's a different employer. It's a gas company, employer. So they're two separate employers, therefore the rules don't apply. However, to your point, as far as if there's individuals that are being funded and providing services under the regional center and under the vendor that are exceeding those requirements, we're hearing that there may be an impact. We're hearing that concern. And that's where we want to make sure that the 2.25% is available to help the providers manage the situations that are before them.
And that 2.25 is the estimate of increased compensation need.
It is. And it's understanding that when you take a look at all of the service, so all of the expenditures that we have under those service categories, some of them, the support hours for individuals may be a limited number of hours, where there's a number of the individuals who may have 24-hour supports, part of which may be supported through IHSS, and the rest of it may be through regional center funded services. Recognizing that across the board, we wanted to make sure that there was an assumption available for a service provider who manages multiple approaches to supporting an individual into the community. Our best assumption.
Good. And again, I know we're not locking this in today, but I think we will be informed clearly by people directly impacted. Thank you.
Thank you very much, Senator Monning. We have two more, or maybe three, more issues to cover quickly before we go to public comments. And the next one is the
impact to multi-year reductions?
Yes, multi-year reductions on community services and supports.
Okay. Over the last several years, a number of cost containment measures have been instituted that have impacted service provider rates. Those measures include rate freezes for most service providers, limiting new service providers into rates that are negotiated by the regional center into a median rate. Payment reductions that began in 2009 and ended in June 2013. For rates set by the department, we do have a safety net mechanism that will allow for instances when an individual has a high risk for safety. There is a mechanism to be able to adjust the rate in those situations. As a result, we certainly share concerns as far as the impact over the multiple approaches that have happened as far as cost containment. We continue to support providers in their efforts to be able to manage how to best support the individuals into the community. We continue to use key indicators to monitor the quality and stability of the community services. Our data does reflect, though, that we have about the same number of service providers over the last several years. That's really maintained a relatively stable number. Additionally, a review of special incident reports at this time is not showing that there's any significant changes regarding those incidents. We were also asked to address regarding the impact of the proposed ICF rate changes. We do have potential impact. The potential impact of the ICF rate change is noted in the future fiscal issues in the governor's budget. Stakeholders have expressed concerns that some providers may not be able to continue if their rates are reduced. This may result in some consumers who are previously funded through the ICF that may shift to regional center funded residential settings. We have been able to continue to monitor the outcome and will continue to monitor the outcome of the implementation of the new ICF rate methodology and continue to work with stakeholders to understanding the impact.
Okay, thank you very much. Any questions, Senator Ronnie? Then we can move on to the Early Start program.
So Early Start for fiscal year 2009 through fiscal year 12-13, there were over 50 different changes in our service system, resulting in about $1 billion in reduction. The department used an extensive stakeholder process to identify the reductions that would minimize the impact to consumers. The difficult decisions were made, and certainly those related to Early Start were among the toughest. The two primary changes to Early Start program included changes in eligibility and changes to the provision of services. Measuring the potential impact to the system due to the issues that emerged later for children who are not able to access Early Start services. It's not something that is easily measured at this time. But we do know that for the first year after changes were implemented, that the number of children served in the Early Start program dropped by approximately 6,000 children. The prevention program that was established at the time to provide a limited array of services to children who did not meet the new eligibility criteria for Early Start. This prevention program served approximately 3,000 individuals in June of 2011. However, that number did reduce in future years. In the next 2 years, respectively, it reduced down to 2,000 children and then down to 1,700 children. While the number of children referred to the prevention program has declined during the fiscal year of 11-12 and 12-13, we have had an increase in our Early Start caseload number. The total number of children impacted by these changes could be as high as 12,000 children since 2009. National literature reports tell us about the benefits of receiving early intervention services. Looking at California, approximately 25% of the children who do receive Early Start services continue to receive regional center services after the age of 3. Certainly another way to take a look at it is 75% of those children who are receiving services do not require the ongoing supports from the regional centers. Any questions regarding Early Start?
So I'm not quite sure if you answered this, but how do you measure the impact of reductions on the access and quality of services that might emerge later, for instance, in children who have not received those services?
Yeah, the impact to those individual children is not something that we have clarity on. It's may not know for many years.
Okay. Is someone trying to track that impact at all, or?
We don't have that within the department, no.
Okay. All right. Thank you very much. Senator Martin? Oh, LAO?
No, we have no comments for that issue.
Thank you. Department of Finance? Okay. All right. Thank you very much. The next item is insurance copays and deductibles.
So trailer bill language implemented in fiscal year 13-14 allowed regional centers to fund health insurance copays and co-insurance payments for consumers if the family or the adult consumer's income was below 400% of the federal poverty level. Trailer bill also allows regional centers to fund copays and co-insurance for those with higher incomes under extraordinary circumstances. Statute does prohibit the regional centers to pay health plan deductibles. The budget for the current year assumes costs related to copays and coinsurance to be $9.9 million. DDS issued uniform coding system. It's a service code to be able to track, the number of expenditures within that category. This was our effort to try to track the amount of copays or the expenditures related to copays, because prior to the implementation of the statute, we did not track this particular service cost. So being able to compare year over year, we did not have that level of detail available to us to track copay expenditures versus now where we have, effective July 1st, 2013, a mechanism to be able to do this. However, since this is a fairly new process, being able to have current and available information that will let us know whether we're achieving, with right now we do have through December 2013, we know that $1.9 million under our assumptions and the data available to us is applied towards copays and coinsurance. How that compares then for the rest of the year to get to the appropriation of $9.9 million is unclear to us at this time. Because we have such a new mechanism for tracking, we're concerned that the newness of this process does not provide us the information that we need to be able to accurately do this projection. We are continuing to monitor this on a very close basis so we can appropriately report back to you as far as the status of those funds that are appropriated. Any questions regarding the copay or coinsurance?
It would help if I turn the microphone on. Thank you all very much. That concludes that last item. We will now turn to public comments, but I would like to make a quick statement. I do know that some people may have come up earlier, not quite in order for their comments, but if you have already made your comments, you do not have to make them again. We will apply them to this part of the agenda. So if any of you are in that category, please know that we've heard you and you don't have to repeat your testimony. Thank you very much. First speaker, please come forward.